Let's start with our candidate one, Doctor.
Yes, sir.
This
This
30-year-old male patient after ankle trauma. Go on.
okay. So this is the X-ray ankle joint lateral view of adult patient. I who has presented with trauma. So I can appreciate that there is. So can I take the so that I can also show with my arrow? I'll request for remote control.
Yes. Okay.
Okay. So can you see my arrow now?
No.
Okay. So I can appreciate that at the distal part of the fifth metatarsal, there is some likely fractured area which seems to be displaced. But this requires, I would like to see it on the frontal view as well, because other than that, the rest, talar dome and the calcaneum, these appear normal to me. I cannot see any other fracture, and I
What
would like
else?
to review.
What else?
So this one, I think this is likely the fifth metatarsal distal, likely the head of the metatarsal. I want to review this area because I'm concerned that there might be any possibility of a fracture in this area. Other than that, I cannot appreciate any significant bone pathology on this provided lateral view.
What
However,
else?
I would like to. Also, I noticed that there is a lytic area noted in um, the cuboid bone, likely, and there's no associated soft tissue thickening. But I would like to see these on the orthogonal view, the frontal view projection,
Okay. This
if
is the
available.
phantom.
Okay, so okay, so on the frontal view, I cannot appreciate any abnormality within the bones. Uh, so can I have a second look at the lateral projection?
Yes.
Okay, so I'm now looking at the soft tissues. I think likely there is some interrupted Achilles tendon in this distal part, which might be concerning secondary to the trauma. And
And
so I
yes.
will discuss the findings immediately with the referring physician and ask for MRI of the patient to further evaluate this and rule out any other associated injury. Okay, so this is the MRI of the same patient. I will first look at the area of my interest. Okay, so here I noticed that there is this is the sagittal plane of the star image of the ankle joint. I notice hyperintense signals within the Achilles tendon, and also, but I am trying to look for any tear. This is likely suggestive of some partial tear.
Where?
Um,
Where?
uh, this one, these
Don't worry
hyperintense
about it.
signals.
Don't worry about it. Look at the calcaneus,
Okay, so
the
I'm going to
posterior
look
part.
at.
Here, stop. What is this?
Yeah, yes. Um, okay, so the calcaneum, sorry, just move. Yeah, the calcaneum, it,
Stop here. Stop here. What happened here? Stop. This is the area of interest. What happened?
okay, so there is, this is the actually, I think this is the proximal end, and this is the distal part of the Achilles that has basically ruptured, and I can,
What's ruptured?
the
What is the
Achilles
name of?
tendon.
Excellent. Show me the ends, please.
This one is seems to be the distal part,
Okay.
and this is the proximal part. Okay, sorry,
Okay.
sorry, this one, this.
Hmm. Scroll and show me.
Okay. Yeah, this one here.
Yes. So what's your final diagnosis?
So it's a basically complete tear. I can see the transected part here. It's
Yes.
a complete tear of the Achilles tendon with the surrounding subcutaneous edema.
Yes.
And and
What will you do
this
next?
is this is urgent finding. I will discuss with the orthopedic surgeon so that they can manage the patient surgically.
What is the commonest site of rupture of Achilles tendon?
At the site of attachment,
No. What else?
um, in the distal part, I'm
Which
not
distal
sure,
part?
sir.
Which distal part?
Mm, Um, I don't remember. I'm sorry.
Yes, you are right. Which distal part? Mayo tendinous junction. Okay.
Okay.
Okay. Thank you, doctor. You did very well.
Thank you. Thank you so much.
Leave the mouse, please. Leave the mouse. Don't worry.
Okay.
Uh, leave the mouse, please. See my colleagues here. What happened when you are presented with ankle X-ray? You should rule out if it is normal. 3 or 4 common subtle findings. In the lateral, rule out any coalition because fracture is very common. I think no one of us will miss fracture, but we may miss any coalition like talocalcaneus or calcaneonavicular. Second, Achilles tendon. You did very well, doctor, when you pick up this lucency here. Really, it is difficult. And if you didn't tell the examiner about the lucency, if you ask him, show me the AP, show me the mortise, he will show everything. Doctor, there are, for example, fracture here. Okay, he will follow you. He will not recorrect you from this pathway, from this pathway to this pathway, and you will lose the case. So number two, look, look here at the soft tissue, especially at the Achilles tendon. Very important. Okay. Number two, if the case is normal and he gives you AP, look here at the distal tibiofibular joint, especially in mortise. Especially in mortise. If you find any widening here, you should ask for leg X-ray to rule out upper fibular fracture, which called Mesneveau fracture. And lastly, the base fifth metatarsal. This is important or subtle finding, we may miss them. Besides that, here, if there are any retrocalcaneal or pre-Achilles effusion or smudged fat here, look here, it should be black like this. Okay, then our doctor asks for MRI. Better to ask for ultrasound. Okay, ultrasound can diagnose Achilles tendon very well. Okay, look here. Your doubt is in Achilles tendon, so at least start from the insertion. Go up, up. There are a defect here, completely. This is the upper end, this is the lower end. The most common site of rupture is 6 cm from the insertion site. From here, measure 6 cm here. Almost at the junction between the muscle and tendon, because this point is less vascular. Okay, my colleague, Achilles tendon is the most difficult tendon in the body to be repaired. It is very major operation, by the way. Big major operation. Thank you so much. Next candidate. Take care also, my colleague. This X-ray may come in the shorts. My colleague, somebody draw, use the marker. Don't draw on the screen, please. Next candidate.
Hello, good afternoon, doctor.
Good afternoon. Doctor, this is 6-year-old female patient presented with 1 month history of spastic walking, spastic gait, no sensory loss or abnormality.
Okay, requested remote control.
Go on.
Sorry, sorry, did you mention the age of the patient?
6 years old.
6 years old. Okay, it was a spastic motion. Okay. Okay, so okay, this is the sagittal MRI T2 of the cervical and upper thoracic spine. I will take a look. I'll take a moment to scroll through the images before I conclude my findings. Okay, so there is a long segment of upper cord expansion and medullary expansion with abnormal high T2 signal extending to the upper thoracic segments. There is also cystic, the distal half of this lesion shows cystic component with foci of dark signals. I would like to check this in the T1 and T1 post-contrast, if possible.
T1 or T1 post-contrast?
T1 post-contrast. So in T1 post-contrast, there is, I'd like to compare, in my practice, I compare both the pre and post-contrast for any enhancement. So what I can say that there is peripheral.
This is the pre-contrast.
Okay. Okay, so there is peripheral enhancement.
This is the pre-contrast.
This is the pre-contrast. Okay.
Mm-hmm.
Okay, and this is the pre-contrast. Okay.
This is the post.
Okay.
This is
okay.
the pre.
Okay, so there is mild. In the T1, there is peripheral high signal more in the lower end of the lesion, and in the nodular small component in the lower end, and there is mild enhancement of this, particularly in this nodular component. In my practice, I will also check in the axial images. However, this is an intramedullary lesion, a long segment extending to the lower medulla with a cystic component. My
Your final
first
diagnosis?
possibility is neoplastic process, likely ependymoma.
What else?
My differential for this is astrocytoma. However, in the young age, ependymoma is more common, and the long segment affection is in favor of ependymoma.
If I told you,
And
doctor, if I
also,
told you this is T1, T1,
yeah,
what
so
else?
this is high. This could be hemorrhagic component.
What else? Especially you
So
feel that there are some levels here. There are levels. So what do you think?
it could be fat component,
Okay.
but it's not common. It's usually not
So
common
if
in the
this fat
intra.
component, if this fat component, what do you think? Give me differential diagnosis.
It's in the lower half of the lesion, fat-containing lesion.
Yes, in young age. What is the name of the pathology? Test containing fat. What is the name?
Containing fat like dermoid, but it's a long
Yes,
segment.
no
It's a long
problem.
segment
What
affection and
is the
expansion of
problem?
the cord. So
No. See. This is a cystic lesion overall.
okay,
Compressing here the cord. The cord here is compressed.
I would like to check an axial images to rule out that it's intra medullary or
Okay, but the
extramedullary.
examiner will not give you all of this.
All
See, look
this,
here.
but I
Okay.
cannot see the cord separate
Yes,
or.
yes. Why? Because this here is compressed by this cystic lesion containing fat. At least gives the examiner some possibilities. Doctor, this is maybe due to the fat, it may be dermoid. Okay. Especially see if you look here in the post contrast, nearly no enhancement. This is see, this is almost fat, almost. Most of
Okay,
this part, the T1. Okay,
okay,
look here. I will show you both. This is the pre. Okay, this is the pre. This is the fat. This is the post. Very minor, yeah, very minor enhancement. Okay, and but I'm trying to help you. So when the examiner is trying to help you, follow him, please. There are high T1 signals.
yeah,
Okay, and the patient is young. Next, second point. See, it looks like eccentric, very large, and the cord here, we don't know really if it's compressed, expanded. At least give the examiner all the possibilities.
okay.
Second question, could the ependymoma be large cystic like this?
No, only
Mm,
astrocytoma will be hollow cord, but ependymoma
yeah,
is not common to do this. Yeah,
yeah, yeah,
present with
yeah.
it.
So we must tell him, doctor, it may be dermoid cyst, okay,
Okay.
teratoma, like this, because it's fat containing. What is your next step?
So I will refer this patient urgently to the
Mhm.
MDT, neurosurgical MDT for discussion, and I will request CT brain to check if there is any association
Is
with
this
this
urgent?
lesion.
This patient need urgent surgery or not? Without brain
Yeah, because it's
imaging?
involving it's involving the medulla, so it's urgent.
Yes,
And
and because it is,
it's
oh,
with all
see the cord.
the long segment of the cord. Yeah, yeah.
Yeah, see the cord here,
So it's urgent. Yes.
markedly swelling. And the patient has 1 month history of spastic gait.
Mm.
This is a child, if we wait more than or deal this patient like regular patient, he may lose his motor function.
Mm. Mm, mm, mm.
Okay, okay, doctor,
Okay.
thank you. Again, my colleague, this case delineates the importance of conventional sign. I think from since 2 sessions ago, I bringing cases that highlighted the importance of T1. All of you must have a look at T1. You should, okay? See, it is impossible. All of this
Mm.
bright signal,
Mm.
you can't miss it. You should talk about it. Even, doctor, this is maybe fat containing lesion like teratoma, or maybe him. Okay, like this, it will be good.
Mm.
Okay, and this is
Okay.
looks like cystic lesion, very large. If you told
Okay.
the
It's just
examiner,
mm.
doctor, it may be number one teratoma, number two, anything else. Okay, but at least give him any hint about that you see the fact. If this, don't worry, doctor, don't worry. In my sessions, I bringing
Yeah.
the atypical cases. Don't
Uh,
worry.
I just want to
I
know
tell
that.
you. Yeah, tell me.
Sorry, doctor. What's the explanation of this of the upper segment? If this is a lesion, the cystic component and the fat component, or the lower part, what's the explanation of the upper segment? It looks like an intramedullary lesion, like
You means this what? This
ependymoma
part?
or something. No, the upper part, the medulla
This
and
part?
upper cervical, the cervical. Yeah,
No, this is edema. No, no. See, doctor,
just
what happened?
edema,
What happened?
just edema.
Yeah,
Okay.
what happened? Doctor, this cyst, either it is intramedullary or extramedullary. We don't know really because it is very large, but it
Mm,
causes severe compression on the cord.
mm, okay.
Okay, this compression results in this severe edema.
Mm, mm,
Okay, this is what happened.
okay.
As I told you before, don't distract yourself in the site finding. Concentrate on the big fire here. Concentrate in
Mm,
the disaster first. Okay? Thank you so much. Take
okay.
care,
Okay.
my
Thank you.
colleagues. Spinal cases, very important. Now in FR, they start to introduce them. I think two of young candidate has been presented with spine cases. It is not difficult, but we are not familiar with it. If this teratoma ruptured, okay, you may find some fat in the brain. So this patient may present it with severe headache. So
Mm,
he will undergo a brain MRI, and you will find fat globules either intraventricular or in the CSF, whatever, and you will not find any teratoma or dermoid cyst in the brain. So when you find or when you suspected a ruptured dermoid during brain MRI and you didn't find the primary pathology, ask the examiner, doctor, I wanted to do a spinal MRI, whole spine MRI, because the source of fat will be a teratoma within the spine, either cervical, dorsal, whatever. This is very
okay.
important. Thank you, doctor, so much.
Okay.
Don't
Thank you.
worry. Even the case before, frankly speaking, frankly speaking. Most of the atypical cases, we are not familiar to them. Even me or anybody when he prepares a case, sometimes we don't know the case. So don't worry. All of us are here in a learning session. Don't worry.
Okay, thank you, Doctor.
Next one. Welcome.
Alaikum, sir.
Welcome, candidate 3.
Yes, sir.
Doctor, this patient has cough, chest pain, and headache.
Okay.
Severe
Okay,
headache.
so
So
okay.
the GP,
Okay, so
see, 1 second. I will give you a very good scenario because this patient go to the polyclinic. They didn't have. They have only chest X-ray. So he requests the chest X-ray for this 70-year-old, I think, male patient who presented with severe headache, cough. Go on.
okay. Okay, so I have been presented with the chest X-ray of a skeletally mature patient, in which the most striking thing I can appreciate that there is a um, well-defined lesion in the right lower zone, and this lesion is radiodense, and I can't appreciate any other lesion within the rest of the lung fields, bilateral coastophrenic and cardiophrenic angles, and the lung fields appear normal. So this lesion, it is seen in the region of the right lower zone, and I can't make out that it is. It seems to be a cavitating lesion,
Excellent.
and I want to have a look at the previous X-ray if available, and if there is any history of fever, if there is any history of constitutional symptom, then it could be cavitating lung lesion, cavitating pneumonia, or abscess. And if in the previous X-ray this lesion was present, so it could be any underlying neoplastic or malignant lesion.
What will you do next?
So next I would like to advise the CT chest with contrast for further evaluation, and to look at the rest of the lung parenchyma. So yes, in the lung parenchyma, I can appreciate that there is a large area of consolidation within the right lower zone with internal cavitation and surrounding adjacent ground glass hairs, septal thickening, and this lesion has the lobulated margins, and I can appreciate that there is reticular septal thickening in the surrounding lung field. So and rest of the in the left lung zone lower field, I can also appreciate mild ground glass haze. So next, I would like to have a look at the mediastinal window to look at
The
the
only
vessels
available.
and
This is the only available image. What's your diagnosis?
so this seems to be a neoplastic lesion, cavitating lesion. Um, so I would uh, uh, so I have the three differentials for this lesion. It could be primary neoplastic lesion with the differential of the um, abscess with the differential of the abscess.
What do you think? This is abscess or neoplastic lesions? One answer.
Mm, So this most likely seen in within keeping in view the age and the imaging features, having lobulated margins and this sort of imaging features. It's most likely concerning for the malignant lesion.
Okay. The GP transform him for the hospital, and they do this because he has, after that, he developed some sort of weakness. What do you think?
Sir, I can appreciate that in the flare sequences, MRI green axial sections on the flare sequence. I can appreciate that in the right parietal region there is marked vasogenic edema. So I am suspecting that there is some underlying lesion like a metastatic deposit, which I would like to confirm on the post-contrast sequence. Yes, I can see that there is a post-contrast enhancing lesion with surrounding
Yes.
marked vasogenic edema. So this is concerning for the metastatic deposit. I would also
Okay.
review the rest of the uh, vein parenchyma as well to look for any multiplicity of the lesion, as well as I would like to look for the meningeal enhancement, any meningeal thickening, meningeal metastasis as well.
Excellent. If I told you, uh, if I ask you, according to the CT, what is your next step?
Sir, next for the lung lesions, we advise the PET-CT. We refer the patient to the MDT so they can do the biopsy and histopathological analysis, and also we advise the PET scan as well to look for any involvement of the nodes, mediastinal nodes, and also we do the uh, uh, whole body, abdomen and pelvis, so that we can have a look at the skeletal deposits as well, any hepatic deposits.
I will change the slides and you tell me what is the best pathway to take your biopsy. Stop me whenever you see it is better.
Okay. Sir, yes, posteriorly we can approach
Okay.
because at the point where was the best slice having the large amount of the soft tissue, because we have to
Okay.
avoid the
I will
necrotic
give you
central component.
choices. Okay. I will give you
Okay.
choices. You will take posterior from here or
No.
from here down near from the diaphragm.
Yeah, from here.
General.
Yeah.
Down or up?
Yeah, sir, from here. Down.
Down here?
Yes.
Here? But you will be very near from the diaphragm.
Yeah.
You will very near. And see here, there are normal lung tissue between the chest wall and the lesion. So we can't take from here. Number one, due to it is
Okay.
very, very near from the diaphragm. Number two, there are normal tissue. So you will lead to pneumothorax. But see here, this is the best, in my opinion, but there are ribs. There are rib. You will avoid
Mm,
the rib either here or here, like this, for example. You can go from here or down,
Okay.
like um, like what here from here. You can. This is very good, by the way. You can make the needle uh, along this axis and take. The most important, my colleagues, when you are taking biopsy from the lung, number one, to avoid normal lung and normal pleura. Here, almost no normal lung or normal pleura. Number two, avoid vessels like this, okay? Bone, diaphragm. When you use ultrasound, by the way, because it is real time, it give you very good access, or even CT guided biopsy. Anyway, at least if you told the examiner, doctor, I should go away from vessels, from reps, from normal lung, from diaphragm, okay, at least it is very good. If you told him, doctor, it is better to be posterior than anterior, very difficult to be anterior. Okay? All of this, at least he
Yes,
will
sir.
know that you have a good idea and you are safe radiologist. Thank you, doctor, so much. You did very well.
Thank you.
Uh, the scenario was The scenario was that started by this chest X-ray, and there are the cavitating lesion here, and the patient is 70. You were very logic when you talk about METs, and it was a METs here. You didn't tell me the exact area. This is the right paramedian, centrum semi-oval, focal or space occupying lesion here, markedly enhancing, and it was the CT. Thank you, doctor, so much. This septal thickening may be lymphangitis carcinomatosis surrounding the lesion. Look here. Ground glass and 670 Around the glass may be due microinvasion and hemorrhage, and the septic may be due to lymphangitis carcinomatosa. Breast and lung cancers are the most common causes of lymphangitis carcinomatosa. Thank you so much. Doctor, candidate 4,
Yes, sir.
welcome.
Thank you, sir. So should I request remote control?
Yes, please. 60-year-old female patient presented 1 week follow-up CT after emergency admission. 1 second, please. After emergency admission due to abdominal pain, nausea, and vomiting. Please announce 1
Okay, sir.
second. Go on.
Sir, I have left.
Go on, doctor.
Okay, sir. Sir, I am provided with the.
Yeah.
So it's zooming and it's not scrolling. Okay.
Let me scroll for you. Let me scroll.
Okay. So please start from the top.
I don't know why it is so zooming. 1 second. Okay. I think it is better now.
So should I scroll or you are scrolling for me?
I'm scrolling. Go
Okay,
on.
sir. So I am provided with CT portal venous phase images of the patient who presented with acute abdominal pain. First, I want to look at the entire stack before commenting on. A patient presented with acute abdominal pain. Okay, I could not spot any abnormality in my first go, and I would like to see again. I could appreciate few air locules in the uterus and in the endometrial cavity and in the vagina. I could also appreciate that there is some air in the endometrial cavity as well. So can you please scroll upward? I want to confirm that there is some. I think this is the sigmoid colon with multiple diverticuli seen. I am now looking at the adnexa. So I think that there is some cystic lesion. No, the adnexa one, I think fine. Okay, sir, I could appreciate some cystic lesion in the right adnexa with air within it. So, and no obvious pathology noted on the left adnexa. Sir, I am thinking in the lines of tubo-ovarian abscesses and endometritis, or some fistulation, because this air in the uterus is not normal. Then this needs to be. I would like to correlate with any history of the passage of stool through vagina or any other complaints like that, because there could be some complicated diverticulitis with the resulting this. In addition to that, there is some just to not appreciate the fluid-filled structure. I don't know it's the tube or if it's. So can you show me on this on the coronal images? It's in the right hemipelvis abutting the right adnexa.
Okay. Okay.
So I think it's in the. I think the sigmoid colon is very closely abutting the posterior half of the uterine cavity.
So, what's your diagnosis?
And there is some. Sir, I'm thinking of some fistulous tract between the uterus and the sigmoid colon, and I would like to evaluate this further on MRI. And other possibility of this that there might be some infection in the uterine cavity, because I'm concerned about the air and this fluid signal and the gut enclosed approximation. So there might be some complicated diverticulitis with fistula formation. So can I want to proceed further with the MRI pelvis of the patient?
No need. You get the answer. Why? Thank you, doctor, so much. What's your next step?
Thank you, sir. Sir, I would like to take inform the findings, and I would like to take an surgical consult because this needs to be. They might the patient might undergo hysterectomy or for the relief of the symptoms.
Thank you, doctor, so much. Look here, my colleagues. You did very well, really. See, one single sign may lead you to a big diagnosis like this. Air in the vagina, in the cervix, in the endometrial cavity, and then diverticulosis and some fluid. Till now, we don't know from where this fluid. Okay. After that, she asked for sagittal or coronal. Here, what happened? Collection between the uterus and the colon and the diverticulosis. So, by expectation, she expect the scenario. It may be the diverticulitis causes this abscess and fistulized into the uterus. Very good expectation. Okay, even she told me it may be. Okay, acceptable. Okay, acceptable. This is the colon, sigmoid colon. It is really abutting the tubes and the adnexia. See, mainly abutting the right tube. So fistulation occur almost here because this is the site of abscess here. The next step, see, look here, my colleague, look with the tube mainly. The next step, surgical interventional. I think no hysterectomy needed here. Why hysterectomy? يعني I think the repair here related to the diverticulitis and maybe to this tube, this right-sided adnexia. Okay. If the examiner asks you how could you be sure or confirm your diagnosis, give a rectal enema of water-soluble contrast. Okay, you will inject it inside and you will see it inside there. Thank you, doctor, so much. It was both diverticulitis, perforated diverticulitis, fistulation. Next candidate.
Assalamu alaikum.
Wassalam, doctor. Doctor, this is 35-year-old female patient presented with a chronic headache. Go on.
Okay.
One second.
I am trying to scroll. Is this me scrolling? Hello, sir. Can you hear me?
Yes, you are scrolling. Go on.
Yes, I have been presented with axial images of brain MRI for old patient with history of headache. This is a T1 sequence. I want to scroll until the last cut and then come back to my finding. I didn't see any obvious abnormality within this sequence. I want to also review the axial T2 sequence for this patient.
Axial T2. And leave the mouse. Leave 1 second.
Okay. So this is the axial images of brain MRI T2 sequence. The images is lagging. So I want to start from inferior and go superiorly. I can see that there is no obvious abnormality could be seen within this T2 sequence, although in comparison between the right and left brain hemisphere, I can see that there is enlargement of the sulci gyri on the right frontal and parietal
What
areas.
else? What else?
I cannot see any shift of midline structure. I can see that there is hyperintense lesion noted within the medial aspect of the right temporal bone, associated with loss of sulci and gyri differentiation. I can see that there is no evidence of hydrocephalus could be seen in this study. As the patient is complaining of headache, I want to see the rest of the available sequence for this study. My provisional diagnosis could be those of encephalitis. I can see also that there is multiple signal voids, collaterals noted within the surrounding the brainstem, and also within the circle of Willis, surrounding circle of Willis. And also I can see that there is multiple signal voids noted within the basal ganglia and also within the thalamus.
What is the name of this sign, doctor? Doctor, what is the name of this sign?
Puff of smoke sign.
What's your diagnosis?
Moya disease.
What is the difference of Moya disease and the Moya syndrome?
What is the next name? The other name?
What is the difference between Moya disease and the Moya syndrome?
Syndrome, it is when the presence of Moya in addition to the symptoms like headaches, and Moya alone is within the patient is asymptomatic.
Are you sure?
This is occur most of the time. The difference between the phenomena and the syndrome is the presence of the symptoms.
No, Moya disease when it is idiopathic.
Okay.
Okay. And the Moya syndrome.
When there is underlying cause such as
Yeah.
ischemia or thrombus.
Yes. Okay. So take care, my colleagues, from review areas of brain. One of the most important is the vessels. Okay. Second point, when you find the pickup, the diagnosis, and the finding, try to concentrate and give as much as possible buzzwords. Doctor, this is multiple collaterals surrounding the narrowed terminal ICA and the markedly narrowed ACA and MCA. This is called buff of smoke. Like this, doctor, this is maybe disease, Moya disease or Moya syndrome. So this is, frankly speaking, Viva exam have like a play. You are presenting yourself in front of the examiner. So try to say as much as possible buzzword. Try. It is very important. Thank you, doctor, so much. Next candidate.
Hello, doctor.
Welcome. Doctor, this is 50-year-old male patient presented with acute abdomen.
Okay, this is frontal radiograph. This is a scout,
Yes.
which I'm trying to look for any abnormality in it, which I can see that there is dilated bowel loops seen in the right upper quadrant.
Yes.
And I can't see any dilated bowel at the rest of the abdomen. The visualized bone appear normal, and I can't see any sign of free air and no branching air above the projected over the liver. Okay, so this is CT axial cut for the same patient and and I am scrolling to. Should I request a control, doctor, or you will scroll for me?
I'm scrolling.
Okay. So I'm scrolling from down the pelvis. I can't see any dilated bowel loops. There's yes here in the center of the abdomen at the transverse colon.
I can see that there is a dilated bowel loop noted here. And I'm trying to check this is from where. Okay, and there is a focal area. Sorry, doctor, can you go up? Yes, here there is a focal area of circumferential wall thickening noted with increase
Don't worry about it. This is a pylorus. We're
okay.
describing the pylorus. Okay. This is CT in which phase? This CT in which phase?
This is arterial phase, so I'm going to check the vessels. So this is okay. I will go with the aorta from up. This is the celiac trunk, and this is the superior mesenteric. Okay, I can see that there is a dissecting flap noted within the superior mesenteric artery, and then goes thrombosis there, and there is thrombosis there in the superior mesenteric artery.
And what
And
about
there
this bowel?
is loss. Yes, there is loss of enhancement of the bowel.
Yes. So
So this is arterial ischemia due to superior mesenteric artery dissection.
what's the next step?
Yeah, so this is an emergency finding. I will call the referring clinician to combine my finding, and this patient need urgent surgical and maybe discussion with the intervention team to for intervention.
Thank you, doctor, so much. Take care, my colleagues. Usually we didn't do triphasic study other than the liver lesion, but here the patient has a bowel complaint and the examiner give you an arterial phase. At least compare the enhancement. See here, at least. If you look here, there are bowel ischemia here. How see, no enhancement at all. Compare the bowel, this bowel with this colon at least.
Yes.
See, there are at least some differential enhancement, no enhancement here, and there are some weak enhancement. So go to the vessel. There are dissection here, and if you follow the superior mesenteric artery, it is totally occluded here. Tell the examiner, doctor, I want sagittal to confirm. This is the next step. This is the sagittal, follow the sagittal. Superior part is dissected, and see, complete occlusion of the lower part. This is ischemic infarction, arterial infarction. See, it's very clear. Okay, the scout was very tricky. It looks like internal hernia, by the way. You are searching for internal hernia, no internal hernia. This is, I think, maybe pylorus here. This one, maybe, because see, almost this is the pyloric canal, because this is the duodenum, and this is the dilated part of colon, but rest of colon is normal. So take care, my colleagues. Don't satisfy of research. It was ischemic arterial infarction of the bowel for urgent surgical and interventional radiology consultation. Thank you for all of you, my colleagues.
Thank you, doctor.
We'll meet again next Thursday. I hope all of you study well. Thank you and goodbye.